Bismillahirrahmanirrahim. Thank you very much, organizers. Wonderful event and very good talks. Really a great learning. And we are missing comments from the senior faculty because of the President Pakistan Cardiology Society is not allowing that. So
He's imposing a martial law.
Complex coronary intervention, the current perspectives. Despite advances in prevention and optimal medical therapy, coronary artery disease remains a leading cause of morbidity and mortality in the world, and so is in Pakistan. The complex, high-risk and indicated patients' interventions, they are very recommended actually according in the guidelines. And we should not be left, these patients should not be left without treatment because they are difficult patients, and the operators, they keep on doing the simple work as is usually done in high volume centers, especially a lot of acute MIs coming, non-STs coming, so simple mid-LAD and circumflex, and no room for the complex intervention. But because according to the guidelines, these patients, they will get definite benefit of these interventions after due homework actually. So they should be dealt with. So CHIP risk, no, CHIP is a specialty, and these high-risk patients, the operators, they are having a separate and advanced training for that. Fellowship courses are there. So this is a separate specialty amongst the interventional cardiology. So CHIP risk assessment contains 3 clinical components: coronary anatomy, location, and complexity of the disease, comorbid conditions like renal failure or diabetes, and concomitant cardiac disease like structural or valvular heart disease along with the coronary artery disease or LV dysfunction and a decompensated heart failure, because these things, they make even procedures more complicated. So we need a comprehensive heart team approach rather than ad hoc decisions by the operator himself for these kind of complex cases. And operator skill and training is very important. So we young interventional cardiologists, they may start these things, but they should be having first experience and proper training, and it's always better to involve a senior colleague along with that. And then institutional commitment is very important, because these are the procedures which will need a lot of hardware, a lot of technology. So this is how we should start performing the complex interventions. Complex coronary lesions include acute thrombotic lesions, chronic total occlusions, bifurcation lesions, left mainstem disease, degenerative vein grafts, fibrocalcific or undilatable lesions, and multivessel PCI. They, by virtue of their nature, they are difficult to perform, have more peri-procedural and early complications, may have less favorable immediate outcomes, and may have more long-term complications like in-stent restenosis and other. So it's more challenging in difficult other situations. This high-risk subset has often not been offered PCI due to technical limitations or a perceived lack of benefit, but it's not the case, as I have already mentioned. So special consideration should be given that there are validated tools and techniques have been developed and implemented for these patients. Anticipated clinical outcome, projected resource and tools utilization, and cost considerations must be done before we plan a complex case. The technology which was invented in 70s, it has made long inroads into the cardiology now, and these trackment devices and lasers and all those things, they are making a great contribution now in the intervention, coronary intervention. And the stents, the newer stents, they are making things much easier for the complex cases to be attempted. imaging OCT like it was invented in 70s, but now cardiology people, they are using it more, and it has a great benefit, and IVUS and all other things. Radiation, new machines, the new cath lab machines, because these complex cases, a lot of radiation exposure will be there. So the newer machines, they are much intelligent in giving a radiation less exposure to the operators and better imaging as well. So special catheters for angulated takeoff lesions or difficult engagements or sport catheters or micro catheters, extension catheters, they are very frequently used in complex coronary interventions. Special balloons, special wires, they have made things easier, and the operators who are doing these cases more frequently, they have developed some kind of liking for some specific type of wire, or one wire or two wires, or some balloons with they feel more comfortable and more success rate. So newer techniques for procedural success and better short and long-term results, they have been developed. So the people know how to use the micro catheters, one micro catheter, how to maneuver it, how to maneuver the other micro catheter, how to deliver the extension catheter. So this is what comes with practice and with the more cases, and with a control environment, within the control environment. So registries have actually shown great promises in reaching to the conclusion that which patients they will be needing benefits, and what type of procedure should be done, which hardware should be used. So the different clinical setups, the data came from different clinical setups, different definition of success and complications, and different follow-up regimens. So the primary purpose of these registries was not to compare devices, but to follow simultaneously the progress of multiple devices in a parallel fashion, using common methodologies and definitions in their early clinical usage. Dynamic registry, that it has shown a very good data actually. Despite rapid growth in the technological improvements and techniques, balloon angioplasty is not universally successful. So this is how it is. And then it shows that there are persistent problems with failure to cross CTOs, failure to successfully dilate elastic lesions, intimal dissection, and abrupt closures, which leads to emergency surgery and restenosis. While characterizing initial procedural strategy and outcome in great detail on the patient and lesion level, we must have in-hospital long-term patient outcomes must be in our mind. Cost-effectiveness consideration is very important. Medical management versus revascularization, the setting of these complex lesions, that's very important. If a patient is, according to the initial workup, will be getting not much benefit of intervention, we should not be doing that. And if the patient can are likely to have more benefits with surgery, we should not be attempting the complex coronary interventions. Variability and complexity of the cost modeling methodology in different setups and different countries, differences in individual costs within one healthcare system and across countries, we know that there are differences. And what are the local trends in the practice? Lack of uniformity and the conclusion regarding the cost effectiveness of various revascularization strategies. So we should have our own understanding. We should use more devices actually once it's needed. Need a careful assessment of upfront cost, anticipated intermediate and long-term outcome, and need for repeat procedure and hospitalization if it must be kept in mind. And also accompany technical planning of revascularization patients. Cost-effective models for CTOs, LMS, thrombotic lesions are different. Additional resource allocation, procedure planning, and sophistication is needed for multi-vessel PCI unprotected left main. We know that if we are doing unprotected left main stem, we must have in mind that the patient may need 3-4 stents or 2 stents or at least like that, and especially in bifurcations. So, conclusions, technically complex PCA procedure remain associated with lower rates of procedural success and higher rates of MACE compared with more straightforward catheter-based interventions. This slide is very important. A chip operator proficiencies and toolbox. We know what type of the arterial access, large bore sheaths, radial access, bilateral femoral access, all advanced techniques like axillary, transcaval, CTO, antegrade wire escalation, antegrade dissection re-entry, retrograde, left main, one stand, two stand, what's advanced imaging is very important. Calcific disease, rota and all those important. Hemodynamic sports, Impella or ECMO or all those needed. Then complication management, coronary perforation, how to manage that must be, and access site complications, these are important. So this is the last slide. Thank you very much. This is a actually picture I took on Jeddah airport. It's a beautiful slide. I liked it very much, and I want to share with this. And this shows that the country can only be beautiful if we have beautiful people. So we must try to make ourselves beautiful so that our country becomes beautiful. Thank you very much.